So do we have
Wes, are you ready? Are you? Shall we get started? Good morning. My name for those of you who don't know me, is Patrick Jones. I'm the director of the Institute for Public Policy at Eastern Washington University, and have been your fearless facilitator in this journey.
You got Patrick.
Speak up.
Yeah. There's a microphone.
Oh boy. I thought I'm loud enough. Okay. On this journey over the last almost 4 years now.
I don't think it's on.
Oh,
Here we go.
there we go. So this is the longest day of the year. If you didn't know that. That doesn't mean we're going to have the longest meeting of the year. We're going to start real soon and then get you out of here at 11:30 and hopefully be a very productive session. Before we start, though, we'll have introductions. And before we do the introductions, I just wanted to ask who has come from the more distant parts of our ACH. So has anybody come from GCACH County? All right, we got one person coming all the way from Ellensburg. Has another one? Okay, all right. Has anybody come from Asokan County, from Clarkston? Has anybody come? I thought we saw Martha from Columbia County. What about Pullman? Whoa! All right. Yeah, we haven't seen you here before, so welcome.
No, I've always been on the phone.
All right. So we'll get started ever so briefly, like right around the room. Just in fact, since I think we need the mic, I'll go around with you, and we'll have some introductions, and then we'll get to the people on the phone. So let's start with Pullman.
My name is DJ Osborne. I'm from Food Medical, and what else do you say? Okay. I'm Dr. Stephanie Fox, I'm also from Pullman Food Medical. I'm Dr. Leslie Robinson. I'm from Pullman Regional Hospital. I'm Truth Quaid, and I'm from Food Medical.
Mike Nichols, I'm CEO at Community Health Center Washington, serving national and past counties.
I'm Erica, Population Health Manager for Community Health Center Washington.
You got it.
Doug McQueen, COO, Community Health Center Washington.
Susan Susan, Planned Parenthood for Greater Washington North Idaho, and the Building Manager. Hi, I'm Julie Whistle. I'm the Director of Strategic Initiatives for Planned Parenthood. Good morning, Stacey Kellogg. I'm with People for People. I'm our Social Services Director, and we have programs in 20 Eastern Washington County.
Morning, my name is Joyce, and I'm 211 Outreach Coordinator for the GCACH County.
Hi, my name is Jennifer Pelositas, and I'm the Executive Director of Impact and Passion Center.
November Altown, the Community Specialist for Greater Columbia, Precinct.
Hi, I'm Marie Raya. I'm the Development of Community Relations for the Passion Center. I'm from Green. I'm from Washington Mental Health. I am the coordinator for the Community Center program.
Good morning, and I'm Christine Melima. I am the Director of Quality and Patient Safety for Foster Memorial Health.
I'm Dave Wilson. I'm the Executive Director of Merit Resource Services for Behavioral Health Organization certificated past YAC and all that.
Sarah Buller-Jones, United Healthcare.
Bill Dixon, the issue Master Gardeners.
Good morning, I'm Barbara Lee with Lord.
Good morning, Gordon Cable. I'm also with Lords. I'm one of the Director of Outpatient Services at the Counseling Center.
Good morning, Courtney Ward with Amerigroup.
I'm Eva Hodges with Tri-Cities Community Health and Core Services.
Mark Lowe's, COO, Sundown and Branch.
From Southeast Washington, Aging and Long-Term Care Council Government and other counties, every county except for this one. I am Shireen Hunt, the Central Metro County Resource Services.
Dr. Jeff Thompson, Chief Medical Officer at Human Services. Always the Tribe Human Services.
So long for Community Health Plan of Washington.
Good morning, I'm Sarah Dusty. I'm the Tri-City Community Health Clinical Pharmacist.
Good morning, I'm Lydia Minnick, I'm a pharmacist with Tri-City Community
community health. Good morning, I'm Sam Waddell, and I'm the Practice Care and Transformation Director for Greater Columbia. Morning, I'm Jenna Shelton, Practice Transformation Manager.
On the hub, Jack Monday for Health Services and Sheriff of Greater Columbia. John Linda Joseph, CFO of Jack Monday for Health Services.
Good morning, I'm Jen. Good morning, I'm Sarah Keo. Second Harvey. Good morning, I'm Sherry Vega, Community Education Manager for the Health Services, Astria.
Jill Bellet, for Astria Outpatient Hospital, I'm the Director for Psych Services.
Morgan Landon, Columbia County and Garfield County Public Health Administrator. I'm Shelley Little, I am a nurse and running the Pediatric Transforming Clinical Practice Grant. Michelle Gruber, I'm the Regional Board Member for Washington Recovery Alliance.
Eric Nelson, EMS Officer for Kennewick Fire.
Yuri Vanegas, EMS Admin for Kennewick Fire. Christine Needham, I'm the Crisis Sustainability Manager. Paige Bernard, and I am the Documentation and Reporting Project for Community Health. Cindy Garcia, Crisis Sustainability Quality. Rodriguez, Tracy Community Health, and the Manager. And Veronica Jarrett, and I'm the Tri-City Community Health, and I'm working with colleagues. Good morning, my name is Ashley Fernandez. I work on administration at Greater Columbia. Good morning, I'm Carol Wozer, Executive Director of Greater Columbia Community Health. Kylie Spence, Director of Finance and Contracts at Greater Columbia GCACH. Diane Bruno, with Finance and Contracts at Greater Columbia.
I'm Wes Lecky, I'm the Deputy Director for the Greater Columbia. And we got a few people who came in, so we'll start with Sandra, and then we'll get to all of those of you up in the Northeast Quadrant, Northwest Quadrant.
Hi, Sandra Flores, the Yakima Valley Farmer Reporting and S2HC representative on the government. Introduce comments from the Yakima Valley Farmer Clinic Behavioral Health, helping out with bi-directional nutrition. I'm Amy McCrae, I'm with Catholic Share and County Services.
All right. Any other last minute entries? I don't think so. So we'll do this table and then we'll get started with a few reports.
Good morning, I'm Brad Lang, the City Life Resources to do home care services and
You're a boss or nursery at the hospital.
then Shears, the Acosta Fire Department, Community Risk Reduction.
I'm Mandy Olson, Healthcare Director of Quality.
So those three who just walked in the room, we're going to pick on you and just tell everybody before you sit down who you are and who you live and sit down. That's one right here.
Yeah, thank you.
All right, so we're going to start here with the report, but as you can see from the agenda, the essence of today's meeting is really about the breakout sessions. So, pardon me?
Miguel.
Oh, hi, Miguel. Would you like to just tell the group who you are? All right, thanks, Miguel. So before we start, though, we probably have lots of people on the phone, and we'll try to make the best of that for those of you on the phone by miking your responses. So if you wouldn't all speak at once, just if you wouldn't mind introducing yourselves and your organization. Anybody want to start first?
Yeah, Mark Walk. I'm Mark Walker with Providence, with Catholic and St. Mary.
Hi, Mark.
Stein Karsbeck, Richland Fire Department.
Welcome.
Johnny Haas, Signal Health.
Hello, Viney.
Sue Jetter, Project Memorial Health.
Rob Waterloo with Providence and Catholic.
Could you repeat that, please?
Yeah, this is Rob Waterloo with Providence and Catholic.
Okay, Rob.
Brian Sandoval, Yakima Valley Farmworkers Clinic.
Hi, Brian.
Megan DeBolt,
Anybody?
Walla Walla County.
Okay, Megan. Hi.
Melissa Sixberry with Yakima Health District.
Okay. Welcome. Anybody else?
Becky Starnes, Community Health of Central Washington, MAT program.
Okay, is that Becky? Right?
Yes.
All right, thank you. Anybody else? Okay, I think we're good then. So, as I was saying, the essence is really in these four quadrants of the room, and you're going to hear a bit about that in just a second. We want you to get to know everybody who is working in your sort of project area, and that's really how we're going to spend most of the meeting. So, to tee off our meeting, though, we always want some reports and some updates, and I'm going to turn to Carol, who just breezed into town last night at 9 o'clock at night from yet another trip to the website to talk to her colleagues throughout the state doing this work. So, Carol, why don't you give your report?
Yep.
Your spiel.
Well, first of all, I want to say thank you and welcome to everyone. It's been a long time since we brought the project teams together. I feel like it's the Blues Brothers. We're putting the band back together. We're putting the project teams back together today, and our sole focus really today is to nail down the project approaches, the target populations, and Wes is going to see us do that. But so it's a great day for your first meeting if this is the first time you've come. You are the people that's going to change the healthcare delivery system in our region. These are our partners. Look around. These are all the partners that you have to do this work, plus the ones on the phone, the ones that are in the team. And it's a daunting task, but when I look around at the scope of the talent that we have here in the street, that I know that we can do it. So what does it mean to transform the healthcare delivery system? The state of Washington, as you know, got a waiver from the federal government to lower the cost of delivering care to improve the patient outcomes and to better the health of all of the population in our region. And we have some amazing strategies and some amazing project approaches that we're implementing. Right now, we are in the process of kind of determining the first round of those organizations that will be kind of our first pilot venturing out into this brave new world. But I want you to know that we will try to incorporate every single one of our partners in the process over the course of the next 3 or 4 years. So we are working on a tiered prioritization of those organizations that already might be ready for doing practice transformation. Sam and her team will be out and about. So we're taking a tiered approach of rolling out our program. We'll learn a little bit more about that. So today is all about the project plan that is due the end of July. So staff is hunkering down. You'll notice on your agenda there is no July meeting. We will be engaged working on this project plan. The project plan is worth half of our money that we receive next year for our providers. So half of $24 million is a lot riding on this report. So you will appreciate the fact that staff is working very hard in delivering an excellent program so that we can get as much money out to our providers as possible. By August, we're hoping that the board of directors will have selected those priority organizations for the first tier. Like I said, we're going to be staging this. And we'll be working then on contacts between August and the end of the year to contract with those organizations and figure out how we can put these programs together so that they're complementary, that there's programs across all of our region. We're not leaving out any county, but we're putting those projects where they're the most important. And given the data and the research that we have, we know where there are high pockets of diabetes. We know where there are high death rates due to opioids. We know that everyone is dealing with chronic disease. It's actually one of those factors that ties all of the projects together. Chronic disease ties all 4 project areas together. And finally, transitional care is all about that care coordination, that discharge from the hospital or that discharge from an institution into a home or a facility. And we know that it takes a lot of community partners to deliver that effectively. So those are the 4 project areas that we will be talking about today. I'm not going to really review all of the things that are in this report. We have a little new report format, but I encourage you to read it. It talks about the mapping that was done. So on the back of the report, Lauren Johnson has been working hard at learning a new program called MapTeaching. So you can see where all of the CSA, the current state assessments, the CSAs, you can see where all those came from. And so you can see that our region was very nicely covered with a lot of partnerships from across the region. We know that we're still getting people entered into the financial executive portal. Kylie and her team, Diane, they're working on getting everybody registered. I know it hasn't been easy. Thank you for persevering with us. But as a result of your filling out the LOIs and the CSAs, we're distributing funds for your engagement. We really appreciate that. And then practice transformation. And the first article that I wrote just said practice transformation, not project transformation. I don't know what happened there. But this is the framework at which we are addressing all of these project areas. This is a framework that's very complementary to every single project. Practice transformation, and especially the model of patient-centered medical homes, that word is, is going through. You guys have reached, I think, that pinnacle. And our Trace Disease Community Health, CHCW, Yakima Neighborhood Health Services, Yakima Valley Farm Workers. Being a PCMH really is a great approach to community-based care, to addressing chronic disease, transitional care, opioids, you name it. It's all encompassed. And so we have embraced that framework as our approach. And we are unique. Not all they're doing it our way, but we think that this is the best way, because if you cannot improve your processes in your offices, then that page, that project area might not be sustainable. So this is a sustainable approach, we think, to our plan. So with that, I think I'm going to turn this over to Wes. He's going to explain the rest of the day. We encourage you, and we would really like for you guys to fill out the name rosters on your tables, because this is a big group. It's hard to keep track of everybody. That once we have your name and your email address, then we can send you all the updates. We can give you all the distribution lists. Am I missing anything, staff?
Just timeline for the rest of the year.
So the timeline for the rest of the year. So project plan is due July. The implementation plan is due October 1st. So between July and September 30th, we'll be working on the actual implementation of how are we going to roll this out. What kind of staging are we going to have? You'll have an opportunity to talk about how we can scale up these projects. We can't do everything at once. So what can we do to add on? Is it transitional care? The paramedics, I was talking to Carla earlier. Is it the paramedics going out to the home and doing training, doing diabetes screening? Is it, what else can we scale up? So you'll have an opportunity to talk about that. So between July and October, it's going to give you time for staff. The project teams will be probably meeting to finalize any areas that you didn't cover today. The board is going to be determining the optional or the first tier of the organizations that will be doing the practice transformation with our project team. We also have integrated managed care that's rolling down the pipe, and that's going to happen between now and the end of the year too. So it's just going to be a very, very busy time of the year. Wanda, did you have anything? Okay. Any questions?
So the rubber hits the road, so to speak, January 1 of the projects.
Right. So implementation actually starts January 1st. Although I suspect that some of the assessments, the PCMH, the rehab assessments, this can be done between now and the end of the year. So we'll kind of roll this out slowly. So it's not like January 1st, all of a sudden it go. I think some of the organizations are already doing some of the work already. But for those that are brand new to this, they will have to do those assessments for staff. Okay, Fleur?
How will the project group coordinate the land, the
Okay, so the question was, how will the project group interface with the local health improvement network? So we have 6 local health improvement networks that we've established across our region. We have one in Kittitas, one in Yakima, one in Benton and Franklin, one that covers Walla Walla, Columbia, another one that covers Columbia, Garfield, Whitman, and Stoughton County. And those groups meet separately. They are on a schedule that is determined by their leadership. So the project team, we encourage you to go to and attend your local list, kind of where community input is found. And I think the most important thing about the local health improvement networks that Ruben Peralta is really managing is that you will have a pot of money called the Community Health Fund that you will be able to access for social determinants of health. It's about $1 million. So we are setting up the lens to be able to distribute that funding, to figure out what the framework for that is. It will be based on your local community needs. For example, it might be an emphasis in nutritious food. And so that's what the lid has determined locally that that's the most important thing. So that there will be a process that you can apply for community funds that will be on the board agenda today. Rhonda's nodding that they're going to be establishing that framework. And so that's the best way to interface with those local networks. So Rhonda and Dan Rickerson kind of share the Yakima land, Susan Greenville shares the Kittitas land, Martha Landman shares the Columbia County and the Southeast Washington land, along with Jeff Davies. Megan DeBolt, I think, is also involved in the Walla Walla Columbia land. And then Kirk Williamson, he's the Benton Franklin Community Health land. So we have 6 lands that we're covering. And then we also are working with the Yakima Nation, who's another really very important part of this. Anything else?
Is that $1 million per health network, or is that $1 million in the overall?
It's $1 million the overall cap. And I have to tell you, our ACH is the most generous with our community wellness fund. We're giving away most of all of that funding through our local health improvement network. Okay. Thank you all very much for coming today. We really appreciate it.
So I want to introduce Wes Lucky. For those of you who don't know Wes, he's this hardworking guy who I think has brought a lot of rigor to the ACH. And I try to, when I come down to that before, I try to not eat by myself, and I consistently ask Wes whether he'll go out and have dinner with me. And he always says he's too busy. So I don't know when he left the office last night, but he's been working pretty hard for this meeting, and I think you'll enjoy what he's going to show. And then Wes and I will walk you through that right after that, just how the breakout sessions might or should take place. So, Mr. Lucky.
So good morning, everybody. I appreciate everyone taking the time to travel here or be on the phone today. This is really an important meeting for us. In the newsletter, it did say project transformation. This really is kind of a segue from what began last year into a different phase of our organization. We are going to try to finalize some things today. As Carol talked about, what's termed the semi-annual report, the SAR, the SAR, not to be confused with SARS, but the SAR is a very important document for us that has some milestones that we need to achieve if we want to get paid. And we were trying to estimate what this document is worth, and we don't know exactly the payout, but we estimated it might be around $13 million. So it's very important that we get the feedback that you're going to provide with us today. So I don't think that's working. So the outline for today, we're going to talk a little bit about the semi-annual report, just to give you some background of what we're trying to do. And we're also going to go a little bit into the current state assessment, which I hear a little bit of a groan for those who worked on that. We know that was a big Goliath of a document, but it really is important for this report. Go to the next slide. So this shows the outline of what these reports are going to look like. This is not the only semi-annual report that we have to complete. We will be doing one every 6 months. As you can see on here, the reporting period for the one that we're about to complete covers January through June, and it's due at the end of July. So at the end of this month, we begin the writing process and the collation and consolidation of some of the work that we're going to be acquiring today and throughout the rest of this first half of the year. Future semi-annual reports will be either at the end of January or the end of July, going all the way through the project timeframe. There are about 5 associated P4R deliverables. This report is exclusively tied to paper reporting. In future years, there will be a mixture of paper reporting and paper performance. And all of you who have been part of this process have now seen the Christmas tree. I hope you know what that means when we say that. Those are our paper performance measures, which are a mixture of HEDIS quality measures, institution utilization measures, access measures, and more. So as we talked about, as Carol mentioned, half of our payment this year comes from this report, which is due at the end of July. So I'm going to come back to that. So this is just an outline of what the milestones are. These are the components of the SAR. Milestone 1 is assessment of current state capacity. That is why we sent out the current state assessment to all of you. That particular document, the survey, has several purposes. But a very big purpose is to collate those findings, summarize them, and produce an analysis that we're going to turn over to Healthcare Authority. The second milestone is to outline our strategy for what's been termed Domain 1. Domain 1, if you hear that, that has 3 major components. The first one relates to population health management, which is really kind of another way of saying health information IT within the practice setting, such as software that does risk stratification, empanelment, and more. Anybody who has this type of software knows what we're talking about. Second component of Domain 1 relates to workforce, and the third component relates to value-based pay. The third milestone, highlighted in red here, is what we are all going to be doing today. We're going to look at the evidence-based approaches that we came up with last year. We're going to look at the target populations, and we're going to finalize that. By the end of this month, we have to come to the conclusion that what we talked about and agreed to last year is what we're going to use going forward. The fourth milestone relates to the identification of partnering providers. Now, the second half of the report asks for some updates around the ACH's organization, tribal engagement collaboration, a project status update, partnering providers, community engagement, and a bunch of other areas. This will not be as extensive of a report as the project plan proposal that we turned out in November. That report, I think, was 200 or 300 pages. It was very extensive. There were lots of attachments. The other ACHs as well as ours put months and months. This is going to be a little bit smaller, but it's going to be very defined. Let me go back. So as far as the timeline for the SAR, as we talked about, it's due at the end of July. The very next day, the IA, or the independent assessor, Myers and Stopper, excuse me, will review the report to just make sure that the minimum elements that need to be included are in the report. And the very next day, they'll report back to us whether or not those minimum requirements have been met. And then they'll let us know, and we have a day to respond to that. After that, Healthcare Authority approves the findings, or the IA, the independent assessor, issues information request to ACH. This is something like a write-back process, which is what we went through with the project plan proposal. And we'll have 15 days to respond back to the independent assessor with their questions about areas of the report. And then within September, the independent assessor finalizes the findings for HTA final review. So today, there's a little bit of a background. For those of you who haven't been here before, last year, our project teams spent a huge amount of work. I mean, we are all so proud and admire what you did. Overall, they met more than 60 times to come up with that preliminary list of evidence-based approaches, what we're calling initiatives, and our target population and more. It was really a laborious process. But we're at the point now where we feel confident that what we have is what we're going to be using going forward. To help with the process today, and Patrick and I will talk about this a little bit more, we've created these template documents. Each table will have one template that the facilitator will use to guide them through a series of questions that relate to some areas I'm going to talk about here in just a few minutes. You will respond to those, well, yes, they can respond to those questions. We'll provide notebooks to you to take notes. And then we'll come back together as a group after the project breakout section and report back to us, and then you can return the notebooks to us, and we'll use that in our processes. We're also going to try to record the conversations at each table. This is really important. We want to make sure we capture all that detail. So again, the findings from your work today, from completing this template, will go into that SAR document. So this is what the face of the project toolkit looks like. In it, there are a number of project areas. There's 8. We've selected 4 of those project areas, as Carol talked about: integration of primary care and behavioral health, transitional care, opioid use management, and then chronic disease and prevention. So evidence-based approaches were chosen out of this document by the project teams, and they were put into the project plan proposal. Today, we get to review and revisit those. This is a sophisticated document that we put together last year. It's a bit of a logic model, but this relates to our selection of target populations. So last year, Carol and I and other members of the ACH got together and did some research about high-cost, high-utilizing, high-needs patients. And the research is pretty consistent here. A small group of any normal population incurs a very large proportion of the cost. In general, this works out to be that the top 5% of utilizers account for about half of all costs within a population. The top 20% use about 80% of all costs. On the other end of the spectrum, about half of the population overuses about 15%. I think that's right, 15%, 10-15%. And then the bottom 15% don't use anything. So our primary focus for project work relates to this area right here, which is the focus of intensive case management. This is what Consistent Care does, Aging Long-Term Care does, Signal Health does, and other organizations do around care coordination. This is a very important group of individuals who have multiple chronic care conditions. As you can see here at the bottom, this is what the literature indicates as being high utilizers. More than 2 inpatient admissions that are not obstetric, greater than 6 ED visits, polypharmacy, visits to active specialists, multiple chronic conditions that may also have high social service needs, functional limitations, disabilities, and more. It's a very expensive population to treat. The next group of individuals is really the focus, this bigger blue area is really the focus of what practice transformation is about. This group of individuals may have 1 or more chronic disease conditions, and they're at the point where they need active management of their care. Again, through care coordinators within the organization, the primary care physician or practitioner, and other individuals and their staff. So a lot of our work is going to relate to this organization. This larger sphere, this is low needs, excellent health, to high needs, poor health. This larger population, for those individuals who might have, they might have poor lifestyle, poor diet, poor sleep, high stress. We think that there's opportunities there through community-wide education, which is what Ruben and his work is going to focus on, as Carol talked about with the Community Health Fund. So today we'll talk about target populations in your group. We'll also get to talk about sustainability and spread. This is really an important concept. We can come up with great ideas, great approaches and initiatives, but if the ACH goes away and these go away, then we'll really have accomplished very little. So spread is spreading the innovation within the organization. How do we spread it across a hospital or a community health center or a social service agency? And then beyond that, how do we sustain it over time? If any of you have ever read Malcolm Gladwell several years ago, he wrote a book called Tipping Point. Tipping Point talks about that when an innovation, this is also built upon the work of Everett Rogers, who wrote a seminal book back in the early part of the last century called The Diffusion of Innovation. If you put an innovation, an effective innovation in place, and get 25% of the population to follow that innovation, and then broadly communicate the success of that. And this pertains to trends, fads, anything that has a tipping point, and then, as we say now, goes viral. If you can achieve that, and again, communicate those gains widely, you can create widespread sustainability. It doesn't guarantee 100% sustainability. There will always be some people in that spectrum who will never get it and never want to change, but you'll be able to achieve a great amount of success. So if we look here within our audience and in the network of the ACH, we have that group of people. We definitely have more than 25%. We have more than 50%. So if we can achieve gains within our group, we can help achieve sustainability. So the next part of this is going to be a review of the current state assessment. Again, this is a really quick review. So as you know, Kevin Martin, thank you for joining. So as you know, the state assessment was issued on May 9th. It went out to 78 organizations. Those were individuals who responded to the letters of interest that was sent out in September of last year. Out of that group, 55 responded, which is a response rate of 70%, which is phenomenal. For 110 question survey, that is phenomenal. It addressed a bunch of different areas, as you know, our project areas, domain one, syringe exchange program, community paramedicine, and more. It's going to be used to complete the semi-annual report, but will also help us assess provider readiness and willingness, as well as prioritization of providers. Volume is important. If we have providers with large numbers of Medicaid clients, that's important. There also has to be a willingness and a readiness on the part of providers to be able to work with us. Philosophical alignment and synchronization of this work is really essential. Some really brief findings here. Out of those CSAs, you can see the sectors that responded. And we actually did get a very broad response from different sectors: behavioral health, care coordination, hospital, medical providers, public health, and more. There was good response across all these sectors. There was actually also a very good response across all counties as well. Every county submitted at least a half a dozen CSAs. Finally, there was quite a bit of agreement as to which project areas that each organization wanted to participate in. So the vast majority of organizations wanted to participate in all these areas. We consider that to be a success. One other question that I've highlighted here, and again, this is going to receive further analysis, and we'll come back at a later date and report out some findings. But one question that was asked here: do you currently have a population health management system? 70% said no. There's a huge area of opportunity, something that Sam and Jenna and Martine and the rest of us will be working on as we go forward, as we work with providers. Does anybody have any questions about what I've shown so far? It's a lot of information in a quick time. Okay, should we talk about the template?
All right, it's breakout time. So we probably have to do quite a bit of musical chairs here, we don't have enough seats around each table, so I envision right now, looking at the incredible turnout. This is the largest turnout I think we've had in months, if not a couple of years. We'll probably have to have at least one concentric circle, maybe two concentric circles. So I hope you'll get to know your neighbor pretty well. It'll be tight. There's really four parts to the discussion. We want it to be somewhat structured, and the first part is going to be reviewing a question of what are the components in each of the areas that you want to touch on. And some of them are pretty straightforward because there's only one or two, but some like chronic care management are pretty lengthy. So just for the purposes of trying to get through all this, we're going to ask the project leads, and I know we have Kevin and Rhonda. Who else are the project leads? Bertha
And then Becky.
and Becky. I saw Becky too. Okay, and Bertha? There you are. Okay, so project leads, you got 20 minutes for that particular one, and you'll get you want to pass out those notebooks, Wes, to each of the four? You get 20 minutes for that question. Then, or questions. Then the second item is looking at target populations. I think you've already spent quite a bit of time in your work groups looking at the target population, but we do want you to review that one more time and be very clear about who you're trying to help with this particular area. So you got 10 minutes for discussion of target populations. Yeah, Rhonda.
Just to be clear, in our different project areas, we're not trying to come together to identify one.
You are not, and I'll get to that. That'll be the last. That'll be the last segment of your discussion, which will be the longest. So just briefly on target populations, and we would ask all you project leads to basically start these discussions with just a review of what you see in your document there that wasn't prepared, and then just invite some feedback. And there'll be more opportunity for feedback, which I'll say shortly. And then finally, in terms of the document that we need, by the way, this is following more or less the template that HSA is demanding of all the ACHs. So the final question is really looking at the expansion or scaling possibilities for each of these four projects. And that could take a long time, but we're only going to allocate 10 minutes for that right now because I don't think that's as critical as the first two and as the last piece. So 10 minutes for that one. So 20, 10, 10. And then the last piece is really to hear from all the organizations that are represented around that table about what their proposal has been to the ACH. And we're just going to have to ask you project leads to do some quick math. If you've got 45 minutes for this segment, if you've got 9 organizations there who say, yeah, we want to report out, you got 5 minutes for each organization. Does that make sense, project leads? If you've only got 5 organizations, then you got 9 minutes for each organization to report out. And then, as Wes said, there will be a opportunity to hear from all the groups ever so briefly at the end of our meeting here. So, quick questions on that, on just the format. It's an experiment. We hope we hope it will work, but I think it'll be a good discussion once we start. Yes, Jorge. Okay, let's talk about the phone. Wes, do you want us? For those of you on the phone, and I've been on the phone myself, I know that this is not easy to do. So, Wes, you want to talk about how we're going to handle that part of the technology?
Good question. So we have one speakerphone here that will be put towards bidirectional integration, and then we have Sandra Suarez, and then Becky, and then who's the third person?
Kevin?
Rhonda. Oh, never mind. Rhonda will be doing her phone. I'm sorry, we changed that. So the phone goes to transitional care. So the start phone goes to transitional care. Rhonda has a phone for bidirectional. Becky will have a phone for opioid, and then Berta will have her phone for chronic disease and prevention. And each one of them will be calling into a call-in service. On your agenda, for those folks who are on the phone, if you want to attend one of those other meetings other than transitional care, you will need to hang up. Please do not put your phone on hold. You will need to hang up, go to the agenda, and look at that call-in number. And give us just a few minutes to set up here because the transition to the groups is going to take a few minutes.
Does that answer your question, Jorge?
Any questions about any of that? I've given each table the template. They also have the section from the project toolkit that pertains to their project area. They also have our section from the project plan proposal from last year that pertains to their project area. And each group is also given a notebook. Please take careful notes. We're going to try to record these as well, but we want to try to be reliant on the notes. And then at the end of the meeting, you can keep the documentation, but please return your notebook with your notes to Lauren.
On the phone, will they have access to the template?
No, only the project facilitator has access to the template at this point in time, and she or he will go through the questions and ask them one at a time. Yes.
Yeah, yeah, right.
Lauren's going to tell you which tables to go to.
Okay, so transitional care will be over here, and then bidirectional is over here. We have opioid over here, and then.
All right.
Originally, we want bidirectional.
So,
we don't have to, but just because that's what we need to make it free. But we can do either way.
Can't change it now.
Okay.
So, it's a good idea. I want them to see. Get the jack. I asked this to you.
I can leave them on. Yeah, because I didn't see them in here. I might have not. I think they're in here.
Oh, there they are.
But I'll leave them up as well. This is transitional care. So I have this phone. Can I grab
I'm going to try to give a minute for a little background noise to settle down a bit. Yeah. Does everybody get settled? Deep into work. Number of new faces on there. In the interest of efficiency, I want to try to capture who's here. So what I'm going to do is pass this around and just treat this first column as a sign-in.
There should be a sign-in. There's one going around the table.
Oh, or use that one. Okay, we seem to have pretty much sorted ourselves out. This is the Project 2C Transitional Care Group. Most of you are new faces. So let's go around real quick and just a one-liner introduction because of the pressures of time. My name's Kevin Martin. I'm the Chief Medical Officer at Kittitas Valley Healthcare.
I'm Sarah Gordon, and I'm the Executive Assistant. My name's Erica, the Population Health Manager for Community Health. Marie Reddout, we can back to questions. I'm Sarah Giacomi, the Director of Donor Relations, Second Prevention.
Hi, Susan Kellogg, local people.
Kira Foster, I'm the Administrative Specialist at Estrella Sun Technical.
I'm Diane Compost from Neighborhood Health Services out of Yakima, and I supervise our care coordination services. And usually Michelle's full of care for this meeting, so you probably remember her, but I'm going to.
Grant Bain, Senior Life Resources. We do home care and Meals on Wheels.
I'm Susan Campbell. I'm probably what most relate to is that I am one of the nursing volunteers at the Union Solutions. I'm Veronica Gutierrez. I'm with Tri-City Community Health, and I'm the Director of Quality.
I'm Lori Brown. I'm the Director for Southeast Washington Aging and Long-Term Care Designated Area Aging Care Agency.
Will you go see policy and accreditation at Tracy? Christina Rodriguez, I'm the nurse manager at Tracy.
I'm Christine Mellema. I'm an RN. I'm the Director of Quality and Patient Safety for Prosser Memorial Health.
I'm Calgary.
I'm the coordinator for the community service program at Prosser.
Alrighty. So this group, the objective is to improve transitional care services to reduce avoidable hospital utilization and ensure beneficiaries are getting the right care in the right place. So for the first 20 minutes, we'll be talking about the strategies and approaches that we identified in the project plan 9 months ago.
Yeah.
And specifically, those were interact. Does everybody have some familiarity with interact or any?
I think you should give it all.
Okay. So interact is a tool set that has been in use in long-term care for probably about 10 years now. For long-term care, we're up to Interact 4.0. They now have tool sets also for transitions to and from assisted living and home. And really, they focus on both communication and interventions that ensure safe transitions. And forgive me, I forgot to include those on the phone. Is there anybody on the phone at the moment?
Yeah, Stein, Kirk, from Richmond.
Sorry, Stein. Shawnee Haas, Signal Health.
And Stein? We'll take it that you're there.
Yeah, I'm here.
Because if you weren't there, where would you be? So the next big, and as background on Interact, I'll just say that about 5 years ago, Qualis and IHI did a collaborative in Pierce County implementing the Interact tool set across all 19 SNFs in the county and both major hospital systems, and knocked the 30-day readmission rate for Medicaid population from about 16% to 9%. Actually 11%, sorry, but it was, they knocked out a third of the readmissions. So it's got a good, strong base. Know that it can be implemented in a collaborative model. The next one that we identified was the transitional care model, which is a nurse-led model of care for older adults that starts prior to discharge and goes through home follow-up. And this is largely the model of consistent care. Transitional care model.
Is that the Eric Coleman?
That I don't
Care
know.
transitions, interventions?
No.
Okay.
It's based on
But
that
that's
pilot
next.
we did.
Yeah, this is related to the readmission avoidance pilot.
Yep.
And they used a hospital discharge planning tool called Boost that used social determinants to predict future readmissions, and a care coordination team that is cross-sector. Care transitions interventions is a multidisciplinary approach towards system redesign, incorporating physical, behavioral, and social health needs and perspectives, also called the skill transfer model. And then we also called out existing family and patient-centered interagency, interdisciplinary collaborative care models. That was largely a recognition of the grassroots care coordination efforts that exist in several counties across the region. Field-based nurse care coordinators, community health workers, and community paramedics. Evidence-based approaches to transitional care, recognizing that this was written 9 months ago and evidence changes. And we also acknowledged the risk at discharge from correctional facilities as a high-risk event. The group at the time made a fairly conscious decision not to specifically target that population, largely because of numbers and community paramedicine. So one of the things that the sense of the group, as we were doing the work back then, was we thought that community paramedicine offered a lot of opportunity following hospital discharge. And actually, since this group last met, there was a study published last October that looked at follow-up from 30-day readmission after discharge from hospital or from SNF. And large number of adults, I want to say the end was on the order of 16,000, were randomized to traditional follow-up with PCP in the office within 7 days of discharge, or a home visit by a nurse practitioner within 7 days of discharge. They found no difference in readmission between the first two groups. But they found that there was a 40% reduction in readmission if there was a nurse practitioner visit within 7 days of discharge. Exactly.
This
So
is
that's an
Shawnee.
example of. Yes?
Hi, this is Shawn from Signal Health. Could you, after the meeting, or have maybe one of the team from the ACH provide where we can find that research? That would be very helpful.
Actually, I will forward that article to Wes. That was published in the Journal of the American Medical Directors Association in October, and I'll have to get back to Ellensburg and scrounge it up, so you'll probably have it tomorrow.
Thank you very much.
Bridges, which, we work with older adults and area agencies on aging. We started with the CTI, care transitions, and around the state, we moved to Bridges because it's, the majority of people in long-term services and supports are served in their home, and Bridges is a more adaptable model that works with the people who are transitioning, who have long-term services and support in the home. So it's a little more flexible than CTI, and it's a train the trainer versus the CTI where we had to send people to either Colorado to get trained, and if they left, the program is done. So
okay.
Yeah.
So we'll come back to that in a little bit.
Okay.
We were talking about key components. We were talking about community paramedicine, and I introduced some new evidence. Leveraging an expansion of existing family and patient-centered interagency, interdisciplinary care models. I would suggest that's probably where Bridges would fall. Expansion of field-based nurse care coordinators, community health workers, and community paramedics. A lot of this actually winds up being at least overlapping. Robust population health management tools, including disease registries and risk stratification. And what you heard Wes say that we heard from the current state assessment is that's probably the biggest gap that we have to fill across all the project domains. Communication platforms such as direct messaging or pre-manage or EDI are Lean and Kittitas is looking at building a digital health commons with pre-manage as one component of it, specifically to address transitions. So there's work being done, and the ACH is supporting some pilots. Workflow mapping to current state, I think we've accomplished some of that. Care coordination by a cast of thousands. Discharge planning that identifies high-risk patients through BOOST, or the problem with PRISM is that PRISM is more of a retrospective tool, and it identifies places where problems already exist rather than giving us an opportunity to get out in front of them. But it's massively useful, to just mindful of its limitations. And development of tracking systems to track and manage referrals and transitions between specialists, hospitalizations, ED visits, and agency referrals. Other than that, we don't have a thing to talk about. So the first thing that we have to do is confirm that what we have is listed in the project toolkit. Carol, is the toolkit online?
You have a copy of the toolkit in your packet.
Does everybody have a copy? That's what I was afraid of. Yeah. So our task in 20 minutes is to make sure that the approaches listed above are contained in the toolkit. Since the approaches above were taken from our report in the toolkit, I'm going to guess that they are. Yeah, it's the same language essentially. Currently implemented within the GCACH. So to what extent do we know that programs that fall into one of the categories I described exist in each of your counties?
So I think the idea behind it is that if there's one of those models that we listed that nobody's looking, then let's not do it. Let's build and scale what we have and let's try it out. So I think that's one important element of that.
Like Lori was referring to the bridges.
Yeah,
program.
right. You know, and it's kind of something you put in element that is very characterized in what we expect to be project. So does anybody feel like doing something different that we don't know?
To be honest, I don't think Crosser on discharge uses any of those to identify high risk. They use me scanning through and stalking patients to send them to CP, which isn't the most accurate, honestly. But I think it'd be great to introduce whatever program other people have had success with. That would be wonderful to have. But currently we don't use any of those to identify high risk.
Is anybody prospectively looking, anybody that in the hospital setting, know if you're using a tool to identify high-risk discharges?
We are, I'm sure, nothing formally.
Do we have anybody here from Virginia Mason Memorial?
Yeah, this is Shawnee. It's really hard to hear with all the other background noise, but we are using a couple of different tools. We have an analytics tool built for our oncology patients that we're using to anticipate ED visits. So patients who've had specific services, we've used artificial intelligence to work that backwards. That's one piece. The other piece we've done is to use PAM, P-A-M, to identify patients who demonstrate low engagement in the management of their medical conditions as an indice of their ability to manage post-discharge.
Shawnee, I know you're having troubles hearing us and we're having troubles hearing you. What were those tools again?
One is an artificial intelligence tool we've used based on our activity for oncology patients. So those who, because there are, while that's not a big breadth of patients, it certainly is a very expensive element of the population. But we are also using PAM, patient activation measure. I've talked a lot, I think, about that in the past, but we're using that in multiple settings. And that's to measure their ability to manage their own chronic conditions longitudinally. So if they're back in for readmission, they're getting a PAM score done.
And PAM is also used in Health Home. That's part of the fidelity model for care coordination.
One of the things that strikes me as omitted from this is referrals and transitions to hospice at discharge, which can be a challenging transition, if only because the expectation from the inpatient side is that a hospice start of care can be done in 30 minutes and it frequently takes 48 hours. And two, because those are people that are at high risk for readmission for symptom control, especially if start of care isn't done in an instantaneous fashion, which it never is, or can it be? And I'm going to guess that all of us have hospices in our areas.
This is Shawnee again. I can report that for Virginia Mason Memorial, for any patient being admitted into the hospital, the provider accountable to the admission order set is asked to identify, we call it here the surprise question, which is that if a patient is expected, would that provider be surprised if the patient passed within the next 6 months? And what that does is it activates the palliative care hospice team to make to loop back around for that admission, to work with that provider around what next steps may be, appropriate next steps may be based on that question.
Anecdotally, I'll say as a primary care physician and a hospice medical director, that question often morphs into, I'm more surprised that the patient didn't pass away in the last 6 months.
You guys are going, I'll have to get used to this strike.
I once had an attending tell me that one of the things he liked about my sense of humor was I didn't care if anybody else laughed. Just amusing myself. And forgive me, I'm just trying to capture the last couple minutes since I'm facilitating and scribing.
I'm also taking it.
Oh, that's good, because otherwise you're relying on a doctor's handwriting. So we've also confirmed, is there any other approaches other than the ones we've mentioned above that any of you guys are planning on implementing in your areas?
So I'm just going to mention, and I know this is that care transitions is a component of health homes, but I don't know that there's there's lots of care coordinator organizations, and I don't think there is a particular fidelity model that each of those care coordinators are using for health home care transitions. It might be hybrid.
Yeah, and one of the reasons, just by way of history, 18 months ago, we were trying to identify single strategies that we could implement across the ACH, that we would all agree that this is the truth, and we could all drink from the same chalice and be enlightened. And it, after a lot of discovery, it became quite apparent that what works in Walla Walla may or may not work in Yakima, may or may not work in Ellensburg, and probably won't work in Garfield, because the needs and the demographics are so different across this sprawling region. So we are going to be dealing with a lot of hybrids, and I think the point of this stage is just to make sure, acknowledging up front that these are going to be hybrid models. Do we have a broad enough description that we're capturing what the hybrid is going to look like in your neck of the woods? Carol, what time did we start? Wes? What time did we start? Quarter till?
About 15 minutes ago.
Okay.
10 minutes ago.
Yeah.
Was it half an hour?
Yeah. We started about quarter till.
All right.
We're on track. So the challenge is we talk about the people talking about creating these networks.
So the other piece of this is, will we be able to use these to improve the P4P or impact the P4P measures between 19 to 21? And again, that comes back to Wes's infamous Christmas tree. Are we going to be able to move those metrics? And I noticed that they've changed at least one of the metrics. I thought it used to be homelessness broadly defined, and now it's narrowly defined.
Yeah. To be honest with you, I wouldn't spend a whole lot of time on this particular section. It's kind of a hope and pray.
Okay.
We have some research and some belief that we're going to be able to move some of these measures, particularly around the institutional measures, which are time necessary as far as inpatient admission, readmission, et cetera. Emergency department. So I would say just a general consensus.
Okay. So with Wes's admonition that we hope and pray, let's all join hands. But, you know, I think for this group, it's one of the easier ones.
because there is a lot of data that shows that just about any kind of peer coordination will reduce readmission, will improve safety at transitions. The key thing is timeliness. The highest risk for readmission with any transition is 72 to 96 hours. So it's what makes tight coordination imperative. So with that, target populations, which may be based on geography, disease type, demographics, or social need. The nature of this project largely defines a good chunk of the population. We're specifically addressing people who are transitioning to or from hospital, to or from assisted living, to or from adult family home, to or from home, to or from hospice, and you can draw those lines in any direction, which is part of the complexity of the work we're doing, is that you can draw those lines in any direction, and they're all high-risk events. So
is the target population then older adults and adults with disabilities on long-term services and support, which is that population you just mentioned? It's not that, so not dual eligible.
I would.
They have to be dual eligible. And do we know from the data, is that the highest risk population of returning those who have long-term services and supports, whether it's in residential or home and community?
It actually is at the highest risk population.
Okay.
The highest risk population is going to be the extremely elderly, Medicare, multiple comorbidities, who may or may not be Medicaid eligible. If they've transitioned to long-term care, they may be dual, but a significant portion of that population is going to be straight Medicare.
Right. And what's your definition of extremely elderly? What's that age?
It's 75 and older, if I'm remembering the definition correctly. 75 or 85.
And right now is, so is that kind of happening piecemeal? So some of those people that are 75 and older and have chronic conditions that are transitioning back home, some of them are getting the support to follow them back to reduce the readmission, but some are just sent home.
Well, so some of those who are at greatest risk of failure wind up in SNF. The current trend in skilled nursing rehab is for shorter lengths of stay. Again, in Pierce County, where there's a high penetration of ACOs, the GCACH Franciscan ACO has an expectation of skilled nursing facilities that their median length of stay for a joint replacement will be less than 15 days. Multicare's expectation is that it will be less than 9 days. Which creates another high-risk transition, because now you have, just about the time you clear the risk window for transition to the SNF, congratulations, we're going to discharge you again. We don't have that kind of ACO penetration over here, but we do have some of the same economic forces, and we need to expect that that's something that we're going to deal with during the course of this project.
And with the Medicare population, obviously because they're not on Medicaid, they don't have those additional supports like in-home care services or those type of.
And one of the things for home health, for Medicare and I believe Medicaid, is that in order to qualify for those, you have to meet a fairly stringent definition of homebound. Meaning that if you can, just not having a car to get to physical therapy isn't enough to qualify you for having a physical therapist come to you. So one of the things that we can think about at transitions is how do we fill that gap? Yes. Whether it's by transporting the person back or by saying that we're going to come up with a mechanism to pay for those supports at transition. at home by a nurse coordinating care is the first important step in that. And then we have to figure out how we actually provide the care. So the definition that we had here to start with was high-risk Medicaid beneficiaries with co-occurring behavioral health and one or more chronic conditions discharging from hospital to home health, skilled nursing facility, or other place of residence, and those transitioning from those settings to somewhere with a lower level of care. Patients with multiple conditions or complicated medication treatment plans, and those with limited capacity for self-care or access to family or community support. That definition means that a lot of it's going to be dual eligible because this is describing almost the same.
I certainly see that every time in clinician that describes all of the discharges. People, from acute care to health.
Would it also not be some of those individuals who have behavioral health issues that maybe don't have the ADL, IADL issues? They don't have a Medicaid service. They don't have those wraparound services. They just, they have high anxiety and maybe inconsistency in treating their behavioral health.
Well, and as an aside, one of the things that we see in Kittitas is that a lot of the folks that we're dealing with are folks who, by exercising their autonomy, choose to put themselves at risk by not accessing care, by living so far off the grid that I can't get an HR to them. We did have one patient last year who we broke an ambulance trying to get her out.
Can this also cover the patients that might be
Yeah, it would, because that would fall under the definition of behavioral health mental illness. That's a DSM-5 diagnosis.
Because I know that that's one thing that confidential is struggling along with the application. A lot of people get in there, going into the toxicity, going out into the same environment, and then coming right back.
So we could add to that definition of the target population transitions to and from chemical dependency.
And maybe people whose behavioral health is being managed by medical providers only, and maybe not being case managed by BHO systems.
Well, and a lot of that is going to be at the next table with bidirectional integration.
Yeah, I was thinking you can co-mingle that care transition with that bidirectional. Maybe that's not the intent of the project.
Well, if you take two steps back, you're exactly right. That's the whole picture. And in order to accomplish the reason that the ACH isn't pursuing the 2B care coordination is because of the metrics associated with it. But in order to accomplish bidirectional integration and care transitions, you're going to do the same thing without having to move the same needles. So a lot of that care coordination piece, you're right, is going to be part of the project work that we're supposed to facilitate. So with the stuff that we've discussed, is there anything that, what would the transformation and spread strategies look like 3 years from now if we do this well? Actually, let me back up a bit. One of the nice things about Interact and the way that it's been done, just for that piece, is that there's already a precedent for doing it as a countywide collaborative learning model. So that you could imagine that we could identify 2 or 3 counties that were most ready to change, and then collaborate with Qualis and IHI and do just spread it county by county and be done within 3 years. So that's one expansion or spread strategy. What else?
I assume when they're evaluating the CSI, because I thought it was CSA,
Current state assessment.
The current state assessment that they're looking at what providers had, of service had indicated that were available by county and what they were doing. Is that correct? So usually if you can expand upon what's already out there and available, and it seemed to me, I can't remember, but were there not 41 of the 50 providers that said that they had some form of care transitions or were interested in it? Okay, so interested. Okay, interested. So I'll just start and then I'll try to shut up so other people can talk. But we've been working since the 3026 grant with the Medicare. We had CTI and of course we changed to Bridges. And so I have people, sorry about that, who are trained in Bridges and some were in CTI. That's been really hit and miss. So we work with Cadillac and Virginia Mason Memorial. Primarily on that, but I do, through our 8-county area, we have direct service offices. We have people who are trained in Bridges and maybe doing forms for that. Secondly, not just us, but other care coordinator organizations with health homes have some hybrid form of care transitions, but that's that's part of the 7 elements that are already being paid for. I think where there could be some help with the spread of that is if there's better system communication. We have Eddie in health homes, but Eddie triggers every visit, whether they go there for pharmacy or whatever, and sometimes it's still delayed for that care coordinator to get out there and do that transition. So those are some areas that you can spread on, and I know that the federally qualified health clinics and some of the hospitals have, and consistent care all have a form of care transition that are out there and could be built. I'm just not sure what county.
So, how many of you are in counties with liens? Local health improvement networks.
Excel. You all have it.
All of them have it. Fair enough. Because I think that's a real resource when we're trying to spread this stuff, to the extent that we're successful at serving our constituency and for our organizations, and can put that out in front. I think that's going to be a dynamite tool. What other partners do we need? The example here is food banks. We rely on Hope Source and you guys.
That's just one thing, kind of thinking about it. Obviously, we don't do like a specific transition from hospital to home, but we have programs that really enhance the transition or make it so people don't go back to the hospital. Like one of them is nutrition. So if people are in the hospital for like specific food needs or nutritional issues, we teach them like in our kitchen, in our home, and in our second harvest distribution center. We teach them not only how to prevent, going back and preventative care, but here's some healthy food, here's what to do with it. So they are getting the food that's nutritional and healthy, and then learning what to do with it. Some people don't even know, like, what's nutritional, what do I need, what do I do with this, how do I cook? And so we teach them that to help minimize the rate of going back into the hospital. And so obviously this isn't directly related to like hospitals and the transitional time, but it's something like if we work with hospitals on getting them access to those classes, teaching them and access to the gardens we have around the area, and I definitely think that helps as well.
Well, and yeah, and that also, I'm reminded of a patient that we recently discharged and retrospectively realized that after shoulder replacement surgery, we were discharging her to a car. And the team did not know that at the time, and only found out provider said that wasn't good. But that is the kind, I'm also, your experience, my experience when I was with the Auburn Food Bank, a lot of times we find those people that we thought their providers thought they had care, thought they had support, and it was the food bank that found out they didn't.
So a big unmet need are homeless, is that what you're saying?
It's certainly a risk population.
Yes. Not only that, what about, we see a lot of, new diabetics too. I mean, and they have we have one that we're seeing today that just keeps, it's a pediatric, it keeps failing. Well, and was like, well, she tries it, we don't give her the food she wants. Okay, so just the education of the family and to help teach them, I think that's a fantastic resource that we hadn't really considered, but that particular family, and then give them homes. And they just don't know how do you change everything. And it's the whole family too, because grandma watches them when they're gone. Well, grandma feeds her whatever she wants. So.
Well, and healthcare have to get, or food banks have to get that information. Again, the Auburn example, we became sensitive to it when we realized we were giving people a cup of soup that had no way to eat it.
Sort of my fear in all this is the tools we're talking about are kind of pre-discharge, and I think the world that exists out there is nothing like they tell you. And so unless you have people on the ground going in, figuring this stuff out, we won't do anything effective.
Well, and I think that's the real value of that, or the real takeaway from that study. I don't think it was anything magic about nurse practitioners. I think it was the fact that somebody went to the home.
Yeah, and it's not. We keep arguing this during the RAT pilot. It's not about health. It's all those other pieces that affect health. And so the transition is much big enough to crack than just getting the health side of things figured out.
Well, that is the rationale for domain one, is recognition that we can talk about healthcare all we want, but all we're talking about is 20 to 30% of outcomes. And if you really want to impact 50% of outcomes, now you need to be talking about social determinants of health and getting upstream.
Yeah, that pretty ugly conversation with folks during that pilot. Because we tend to figure on the people that are coming back a whole lot, 6, 7, 8 times, and the very highest risk folks. And the bottom line is, my old life was as a firefighter. We would go into the wildland areas and say, we can't save those houses. As much as I hate to say it, there are folks who are not going to make any difference in their behaviors. Perhaps we step back a bit, and that's why I like the kind of the concentric circles we're looking at. That second one is the most interesting one. I mean, not the first one. We can throw all our resources at that and make no difference. We've got to figure out where we land and where we can most of that.
That's a great point. I know we found out that we have a population that we are very, very effective with, and we have another population that we can hit our head against the wall all day long. It doesn't make a difference. So you kind of shifted our program after we came off the federal grant, because we're like, hey, we got this data back that showed us we're not doing anything here, but man, we need to focus our resources here because this is working. And that was at 57 range, and these chronic illnesses, we really made a big impact, and we had these other ends of the spectrum that we were really trying to go after. And he's right, because I'm gonna tell you, firefighters and EMS are realists. They're like, and I have to tell them every day, yeah, I know we're gonna go see him because we have to see him a couple times a year, but there's no point in seeing him every time because So, one of the things I want to point out with the care transitions, and I'm sorry to put this, but with bridges, the component why we got rid of the CTI, one of the reasons is that it doesn't look at referral, and you do have to refer out to all those different social services, transportation, home delivered meals, congregate meals. However, a lot of those organizations, those social service organizations, have capacity issues because they have limited funding, or the funding so specific to a certain population, like Medicaid, or if you're looking at the Medicare only without Medicaid, there's just some limitations with those services. you had just mentioned the person who was homeless, the lack of affordable housing, et cetera. So when you're talking about social determinants of health, it's really hard to make a good health outcome if somebody doesn't qualify for all those social services.
That's what we're going to figure out here, though, is you spend $100 to feed somebody to save $1,000 in a minute.
Right.
Yes.
And that's what the waiver's all about, right?
So we're actually on track in terms of time. Carol, do we have adequate answers to the 4 questions that were?
Read the questions again.
The last one is expansion and scaling, which is where this started. So transformational strategies and approaches, verifying that we have alignment, that we have good capture of what's out there. Target population, and expansion or scaling of transformation and strategies.
So I'd like to go back to the target population because this is getting to a very important part where you guys feel that the effort should be made. We agree with Grant that we're not going to be able to save everybody. Unfortunately, it would be wonderful. But I think is that a different target population? I guess is the question. I'm not.
And are we trying to walk away from here today with the definition of who our target population is?
Yes.
Yeah, because I don't feel like we're kind of all over the place.
So the
With that, I'm not very clear on.
the definition we came in with was high-risk Medicaid beneficiaries with co-occurring behavioral health and one or more chronic conditions discharging from hospital to home, health home, skilled nursing facility, or other place of residence, and those transitioning from those settings to somewhere with a lower level of care, and patients with multiple conditions or complicated medication and treatment plans, and those with limited capacity for self-care or access to family or community support. And we added to that the notion of to and from chemical dependency treatment.
Now, is this something too that we have to choose for the whole 9 counties that are included, or are we going to break it down by each county? Because I feel like the target population, like I said earlier, might be totally different in Waterford than it would be in Clarkston.
So we can define the target population for the ACH. In your community, you're going to decide what piece of that you can take on. To the extent that you're taking on a broader population or a population that isn't a subset of that, you're going to be doing things that the ACH at some level will decide whether or not that's part of their mission. But there's always been a recognition that anything that we do is not going to be, we can target the Medicaid population, but the systems that we create to do that are going to have a broader scope. Unless we're just going to say we're only going to provide this service to Medicaid. Anybody here planning on just improving transitions for Medicaid population?
And we don't know.
And so we
provide the care to everybody.
Exactly. So we're using this to build the systems and to target that population with the knowledge that the broader population benefits.
But your metrics are going to be on the Medicaid population.
That's what that's what the ACH needs to do in order to get money in order to support us.
Exactly.
But your data you're collecting is on that, which that already creates a percent.
But if you're going to spin the needle, you do have to focus on a Medicaid population.
Yes, absolutely. Yeah. But what you're creating, just like our program, we see everybody from newborn to 100 something years old, irregardless. But you're going to submit data, and you're going to end up on the Medicaid subset, but you do have to kind of focus. I know it is really interesting. There's a lot of people here who have a lot of experience, but you do have different populations, and it's a different problem. So if you're looking at your under 50 population, you're looking at your younger population, they have a different issue. So if you're dealing with your, it's a completely different focus. I don't know how to.
So again,
we have Medicaid that are 20-something years old still, and we have kiddos in BC. We have
there's 2 conversations that are both important and need to be separated. The first is where is the greatest need, and where can we have the biggest impact? The second is what is the population that the Cure Transitions Project can make a difference in? What is our target? And one of the things that we said in this group early on was that because it is population is defined for us by an event. It is people who are moving from settings. One of the categories that we struggle with the most in Kittitas is the disabled elderly that prefer to live in dangerous, unhealthy conditions and protect their autonomy rather than sacrifice that autonomy in the name of safety. And that's something I'm sure. And that's a huge challenge, but because they aren't transitioning, it's really beyond the scope of this group. So we all have our white hats on, but we need to focus just a little bit on.
But they are ending up.
Sometimes. Yes. I can tell you a horror story later about what it took to get somebody to the hospital, but we could intervene upstream, whether through integrated behavioral health or by addressing social determinants. To some extent, what we're dealing with here is the group that's already failed at least once because they've gotten to the hospital.
Carol, do we have demographics and on this that give us more better, stronger numbers?
I was going to ask, because it seemed like at the beginning of the ACH, Wes did the demographics for our region, and one of the high areas was actually children and young adults for, I want to say it was maybe ER. Yeah, okay. But not, okay.
Higher age group, higher age population.
Do you think the ACH has any appetite to take the target group forward without that little bullseye group that in the high use small?
I think we can justify whatever the project is on the news. I think if you want to move the metric, you're not going to move them. The highest risk population is a little bit different.
Yeah.
Bi-directional, I don't know.
I'm just wondering, from an emotional point of view, is that palatable to the group to take that forward? As my background,
Do we have the demographics on there to show us what that population is, that super high utilizer? What are their diagnoses? What do you might get?
So you're talking about emergency department?
Well, care transitions, but that does include ER. I mean, you're transitioning in your things that you're trying to fix is, make sure they get a follow-up after they go to the ER for X number. So that does include that. But those people who are the highest, the very highest utilizers, that little group, what is it, 5%, top 5%?
That use 50%.
Yeah.
50% of the.
What does that group look like? What's the demographic, what's the diagnosis of that group that's such a the highest utilizer? Do you have that?
So in general, that's not a homogeneous group.
Okay.
Right. That includes, varying types of care problems, varying types of demographics, and frankly, varying types of social service issues. Okay. So it's not a homogeneous population. Now, the high utilizer population in the emergency department has a little bit of carryover, but for the most part, again, it's just a mix of different types of individuals.
So what about the next group down? The one that we have the little circle, and what about that next?
It's 40%. So again, that's the individual. That's the focus of the practice transformation efforts. Those are individuals who probably have one or more co-occurring chronic illness. And the strategy for that, those are people who are getting into the office, see their provider, but maybe there's not planned proactive care there. The goal is to do that around practice transformation through some of the things we talked about as far as population health management and some of our other tools.
And remember again that there are other things going on in the ACH. There's the practice transformation, there's the domain one work, and a lot of that is where we're going to impact the people, but we'll try to impact them before they hit that bullseye.
These ones we said already failed.
So,
but they can still be.
And I would actually suggest that with the one addition, we've got a pretty decent definition of target population. The other thing that we have here is
broad.
Yes.
Yeah.
Well, and
yeah.
the other thing that there's time in the agenda for, and I actually think for those of us here at the table, it may be a huge benefit to open up the round table. If you haven't signed in, please make sure you do. I want to capture this. Oh, good. There's another page. I was afraid that only 4 of us had signed in, and I was getting concerned. But by my count, there's probably at least 12 agencies around the table. So what I would suggest is we're going to do a little speed dating here. And I'm going to give each of you 90 seconds to tell us about, again, your agency, but where you see being able to impact transitions in 2 sentences.
Oh, well, that won't work for me.
You got that. There's a method to my madness. The reason that I'm putting a very short time frame on this is because I want you to say something that's going to prompt somebody to ask you some questions. And if we do it in 90 seconds each, there will be time at the end for us all to talk. Rather than doing 5 minutes on your organization, let's do 90 seconds on your organization and then let's do some cross-pollination.
So can you start?
Sure. My name's Kevin Martin. I'm on the board of directors of the Kittitas County Local Health Improvement Network. I've been part of the A team almost since its beginning, and I'm the CMO at KVH. A team is a group that is largely driven by EMS runs, also by identified risk factors in clinic and ED, and we are dealing with the most dire of the dire. Over 3 years, we've intervened on 106 people. Interventions have ranged from obtaining guardian ad litem to building ramps as a way to reduce admission. Oh, most important thing, we represent the 2 biggest primary care systems, the hospital, 2 fire districts, 3 assisted living, skilled nursing facility, aging and long-term care, Meals on Wheels, and hotels. Next.
I'm Carla Green, professor with our community paramedic program, and I'm really interested in seeing how our program can reach different people, because the populations that we're talking about, we see some of them, but not all of them. I really agree with Grant that there's a certain population that our guys kind of beat their head against the wall. We go and we feed them out of obligation, but the expectation is very low. There's one gentleman that he's in the hospital almost monthly with pancreatitis. He drinks every day. He does meth. They stop by and see him. He's real polite, smoking his meth, and there's alcohol everywhere. And we tried to get him set up. We tried and tried. You know, he has his own. I don't know if they're like, I don't know how to help him. You know, but things like this, like when Sarah brought up their classes, this is a girl we were talking about today. We're struggling with this little girl. She's 9 years old, 200 pounds. She's had multiple surgeries. She has high blood pressure. She has diabetes. She has sleep apnea. She is really, really, really a sick little girl. And everyone's struggling with how to change behavior. And so I'm excited to look at this and say, what can I do to reach up to the population and see, because I do think there's some that can't be saved, but I think there's some that can and that we're not trying to look at yet. So I'm excited.
Perfect.
I'm Christine, professor, and I just will kind of dovetail on what Carla said. I'm actually very new to the organization and still trying to figure out the nuts and bolts of it all. And the community paramedic program that she's speaking of has just been phenomenal. I've learned a lot about it over the last couple weeks, and it would just be nice to be able to dovetail onto that with something that we can do for discharge planning through the hospital as well, some kind of connection. And the idea of a nurse practitioner, you know, making those rounds as well as a paramedic, you know, but they can't be out there all the time. I mean, they're also out doing runs, you know, for 911. So just be interesting on how to improve that.
Next.
So my name is Christina Rodriguez. I'm the nurse manager for Tri-State Health. So since we are a clinic, I think our word transition or how we help in that aspect is we do a lot more of the ED utilization and making that whole segment. We reach out to the patients and try to see if they can get in. I think this is after the year, because one of our struggles is getting within the 70 or 90 because limited providers and access to facilities. So I'm really glad to hear. I mean, I don't think it's great if you get such eager chances.
I think one thing is really neat that we've done with paramedics, but you do have such great EMS down here in Tri-City. Boy, if you could even coordinate
them where they could try to go out to the, I know you guys are busy, you're booked, but maybe you could say, hey, this patient we can't get in, maybe they can pop out and see them, get vitals, do an assessment, at least talk.
Well, that's not.
To give you a.
I work in quality in Tri-Cities, so we, as far as I look at transitions, I look at more as that preventative. So how do we identify and see those things and do that preventative care, whether it's chronic conditions, those transitions, those kinds of things, so that we can assist in those metrics.
So I'm Veronica. I'm with Tri-Cities Community Health and I work in quality. So the work that we do, what I'm responsible for, is very much data-driven. So patient performance, utilization, and cost measures. And so when we start looking at what's driving our risk pool, and it's all that utilization and by emergency room, high utilization of the emergency room, readmission. One of the things that I think we struggle with, and what I like to learn from how we can partner with the community, is how do we transition in terms of our providers are so booked. How do we get them in? How do we coordinate, collaborate with hospitals, case managers, and care coordinators to make sure that there is this smooth transition? Getting those notifications promptly. We're such a busy system, and we're seeing so many patients. So that's a true challenge. And the access and the communication from where the patients are coming from is so critical. And so that's an area that I think we can, as a community, we can look at improving.
Well done.
Good. Southeast Washington Aging and Long-Term Care is an area agency on aging. We do the continuum of care for older adults and adults with chronic conditions that are on long-term services and supports in the home. So we contract out a large portion of our services, home delivered meals, congregate meals, and legal services, adult daycare, adult health, etc. Direct services, we have case managers who do the Title 19 support. We're a lead health home, and we have the Aging Disability Resource Center, which helps seniors and adults with disabilities to navigate services, and that's all. We can go out to the home to do that, set up a care plan. We have the unpaid state family caregiver program and the Massachusetts, which is a pre-Medicaid for unpaid family caregivers of people who are caring for people who are unpaid or have chronic illness and disability. We're only serving about 1% of the population. The area that we haven't talked about is dementia. We know that with people with dementia, because they come in with other kinds of disability, other kinds of, presenting problems when they go into the hospital. Really, what it is a cognitive decline, and and the evidence-based care transition models don't work very well with dementia. So.
Bobby. Put it in a bucket of water.
We'll come back.
There are two ways that I interact with transitions, one being at the homeless shelter, where I coordinate a group of nurses who volunteer, focusing on prevention, mainly wellness, and use of primary care versus the emergency department. The second way is I'm a part of a group called the Faith Community Nurses, which is a group of volunteer nurses who volunteer in their community, whether it's their church or hospice. Many of them volunteer at hospice, at the shelter, at Grace Clinic, at SOS Clinic in Walla Walla. So there are many ways that we can use volunteer health professionals to help supplement the needs for transition to care, transition to home.
And our two programs, I believe, are the best early warning devices that exist in the community. We have close to 1,000 staff who are in thousands of homes, sometimes daily. They see things and often know those people better than their own family knows them. And so they can alert to issues either before the first problem or between the first problem and trying to mitigate the second. So in terms of transitions, that's where I see us fit. And we have support services, nutrition, and home care on top of that. I think our folks see the stuff developing probably before anybody else, certainly before people in medical.
Diane, again, from Neighborhood Health Services. I supervise the care coordinators there. So I've really seen the benefits of getting out to the patients as soon as possible. So just reiterating that. I also work with maternity support services. So I'm really pro going out to the home-based models. I feel like that's where you really capture so much more of the holistic picture. I feel like that's really important. Pre-manage, I think that's a great benefit of our clinic. I see a whole, we have our patients that are helped home, but then we have our patients that aren't qualifying for that program. And so getting those patients, those home visitors, and that funding would be really beneficial to our clinic. We also have our care coordinators working specifically with a provider as well. And so as social determinants to risk come up, we're able to assist the provider with some of those tasks or resources that they need.
Very good. Since we've come to an empty chair, let's go to the phone, and then we'll do the two of them, and then back to Cheyenne. Shawnee, sorry. Can't read my own handwriting. Shawnee? Stein?
Maybe they got disconnected.
Damn it, transfer to Stein.
You had your turn.
I'll continue on then. I'm Sierra. I'm from Astoria Sunnyside Hospital. And with the network we developed with Astoria Health, we have 3 hospitals, so we really focus on that ED, but we also have the abundance of clinics with tons of different specialties, so we're not really limited in that aspect, and we're really ready to help reach out to those community-based organizations that can really help us improve that transition of care. Where we lack those most is staffing needs. So in each of our organizations, we do not have adequate staff to actually, start these programs. So we need, at Sunnyside, we're the smallest one, but we only have 1 social worker, 1 caseworker. That's kind of it. And, it's kind of like, okay, well, how do we initiate and what are the positions that we need to develop first and foremost? And then how do we keep growing it? Because we're kind of we have all these great elements in place, but we're missing the people to pull it all together.
Hi, Stacey Kellogg, People for People, and our agency really provides services that connect people to the social determinants of health. We have the senior nutrition meals on wheels and the congregate meal sites. We have the 211 information referral call center that is connecting people to a comprehensive list of resources in their own communities. Our non-emergency medical transportation for folks that are on Medicaid to get to those doctor's appointments, as well as special needs transportation. So really what we want to see in all of this is that we keep talking about how important the social determinants of health are in the health of that whole person, and just making sure that people are remembering to make those referrals over to programs such as ours. And then also looking at how within this model can that be sustained in a funding way. So, for example, we'd like to see a prescription for meals at discharge, understanding that with Meals on Wheels, it's not just the meal, although that's very important, but it is the volunteers interacting with those people on a daily basis. So that's kind of where we're moving at.
90 seconds or so.
So I'm Sarah. I'm with Second Harvest, and we believe in healthy food every day for every person. And so what we do is we have a mission to connect the dots. So we support many agencies, which include Boys and Girls Club, UGM, the Gardens Around Town, nutrition programs, and our mobile markets, which bring food to people in the community where they have needs.
So we're
just giving people the support that they need to live a healthy life, especially with fresh produce, having that availability, and able to make those.
Oh, yeah, I was off on my timing. I thought we had 10 minutes more than we do. Go ahead.
So I'm Matt Davey, and I'm kind of the regional director of the Yakima Valley Pharmaceuticals Clinic, which we have in Walla Walla. And so we're a community health center and primary kind of home health model. We schedule from kind of, if you're familiar, advanced access sort of model. So we try to get our patients in today, tomorrow, third day, how long. So we talked about treatment a little bit. We've got a process where we're calling every patient who has an ED visit and getting them in that usually within 7 days if we're right staffed. We have embedded into our practices dietitians, behavioral health, and then community health workers. So I guess we kind of think about it as from an ER perspective, you're catching the people that are going there, but then from an upstream perspective, we've got some folks in our clinics that are helping to connect to both of the organizations with our experience to needs of where they transportation and whatnot. I think in the Walla Walla area, we try to partner with any community organization that we can. You said it is knowledge. It's helpful to have the knowledge in your organization from a community health worker. Maybe this person's part of this group that would fit into this service. So I think that transition that help us help their patients. We're starting to
I'm trying to keep some time with you.
My name is Erica. I'm the population director for community health in Washington, and we have clinics where we service Yakima County area and Yakima, 2 clinics in Yakima and also in Allenburg. We've integrated with what we call a population health model that includes nutritional services, as well as getting contact for social workers and support workers that are also receiving a lot of these Eddie alerts and that. We are working with them, and we're also trying to implement a risk stratification tool that we will be doing.
My name is Peter Osborne, and I'm from Pullman, from Bliss Medical. And our organization has kind of taken a leadership role within our community in trying to help transform the healthcare model that we're currently using. We are, I would say, I haven't heard it around the table, so I hope I'm in the right spot. But I kind of feel like the best way I can describe this is that Hurricane Katrina situation where FEMA's trying to get all of their resources to people, and then there's no phone system, and the electronics are down. That's what I feel like sometimes within healthcare is trying to reach out to different organizations. We have the people that can, coach, or different people that can provide the transportation. We have the people that can provide the food, but how do we get that in a timely manner? I'm very passionate about trying to figure out a way to improve our technology and our communication, decrease those, decrease barriers to care, increase the access. Because I feel like there's enough hands to help. It's just those barriers in our communication and our technology. So I run our portal and try to help do education within our community on ways to better utilize portals. That is painful. It's painful to try to get people on board with it. And so I realize that not everybody has access to technology, and that all of our different EMRs and EHRs are all different. But at the same time, we got to find a way to do this better, or all this effort, it's a little bit like having all the resources but not being able to parachute it in.
Perfect. So you mentioned technology. One of the things that we're doing
Am I at the wrong table for that?
Yep.
Oh.
One of the things we're doing in Kittitas is, with the support of the ACH, we're building a referral backbone that will allow us to capture data on the people we intervene on, as well as manage referrals. We're also going to be coordinating GNPs and community paramedics, probably deploying them in pairs after discharge, especially for some of the places that I don't want to send I also supervise our GNPs, and there are places I'm not going to send them alone. And having somebody in a red truck can help. One of the things that I think is a common thread for most of us, like you say, is breaking down the silos. And in our health network, we early on asked ourselves, how would we know when we were mature as a network? My answer was when we stopped introducing ourselves by the organization that sent us and start just focusing on the work. 3 minutes. Let's keep it aside for 10 minutes.
Well, I think we just created a new model. I like it. It's a golf model. Go out to the hump.
I do it as a hospice medical director all the time, and it's amazing, A, what you learn, and B, what you thought was possible that you get out there and you just kind of, that's not going to work.
I like your comments about the technology, because one of the things that we've discussed in previous meetings is the siloing of communications. So Catholic Epic and somebody else has yet there's no community interoperability. There's no ability of the community as a whole to communicate using technology, and we need it.
We need it. It's so critical. I feel like those are the conversations. Billing and technology tend to not be part of these innovative measures, and then at the same time, those are like such a critical component to success and sustainability for us. I don't know if I'm just becoming more cynical the longer that I work with things. I've been in healthcare for 11 years, but it just feels like if I don't know if we're going to hit a point where we have interoperability and we all have the same system, it's going to keep adjusting, right? But we got to find a way to still speak a common language. And so that's the part where I feel like we can do that. We have the ability. How are we not doing that? How are we not utilizing the resources that we have with technology?
It's interesting because on my way to this meeting, I was on a conference call. Said something about my life. But it was actually about the digital health conference. And the comment that the consultant made was that interoperability for population tools is light years ahead of where it was 5 years ago.
Sure. Yeah.
So there's reason for guarded optimism.
Yeah, it's true. And it is hopeful. It's just really hard when you have such a gap, where you get that information and there are patients, especially if you're looking within a window of so many hours, so many days to try to get people in. It's just, it does not feel very good to see where it's like, how can we still have this gap?
It would be great for them if they could, if they were on CR on Epic, and so it's nice they can send their information to the primary. It's nice the referral of that thing. Like, man, I could send this to Second Harvest, and I could tell them I could put notes in there, or I can send them to, Meals on Wheels or whoever. It would be so nice if that referral was that easy too, to reach out to the community where you're in there, you're sending this information out, and you just go, hey, this person really needs this. Only that would be hopefully it would be great. Don't you guys have for your network to have
We don't have CDOs, but we have behavioral health, so we don't have CDOs that are really active in data.
Where we do our group report out. So
basically we have this comprehensive and we have research. Thank you all.
And or describe to the report out to the larger body. I think we know total like interaction before.
Yeah, we have actually a lot of, like, these are always one of the secondary districts. We utilize travelers for a lot of options, of which the curricular contract labor is inclusive, and not only that, it's just not the body. So, but my,
Can whoever's leading this get closer to the microphone? I can't hear anything.
What I'd like y'all to do is basically cover the three main sections that we asked you to do. Sort of the alignment of strategies, market organization, and then possible expansion.
Hello? Can you hear us?
Those of us on the phone can't hear what's happening in the room. We're beans.
Can you hear me now?
I can hear now. Is that somebody in the meeting? Not on the phone?
Yes.
Okay.
That was Kevin. So,
that's Kevin. But you're not. Are you there?
Yeah, I'm here.
Okay.
Hi, Liz.
Thank you. Yes. Now I can hear you. Thank you.
Fellow Kinetassian.
Which means she's putting up with fallacious echo to interact with us. So when we got to talking about target population, we found there was one significant omission that we thought we should capture, which is transitions to and from chemical dependency, especially serial transitions to and from chemical dependency treatment. So we want to include that language in the target population. When it came to spread, because most of our efforts are grassroots, it looks like that'll be fairly easy. And I think probably the most important thing going forward would be facilitated conversations between the efforts in each of the 9 counties in the nation to learn best practices and steal from each other. It's been said that R&D is very important. Rip off and duplicate. Any questions?
I'll just add that, Kevin, I think there will be an opportunity. I mean, staff and Carol have been talking about so-called learning collaboratives of these groups that we can carry forward to have those continuing conversations. And one of the things we talked about in terms of spread is the fact that there are specific components in the transitions toolkit model, which has been done as countywide collaboratives elsewhere in the state with great success. And it's easy to imagine that we could partner with Qualis and IHI and have a large county, a medium county, and a small county as a collaborative and get through the entire region before 2021. Great. Questions for that group on transition? Right, covered it well. Where did Rhonda go? There she is. Okay. Bidirectional configuration here.
So when we started meeting today, I think it was Patrick that said that our work group had met about 60 times before we took a hiatus or rested. So I was a little nervous when we sat over here because I think there were only 2 or 3 of us from that work group that met during those 60 times. We sat at the table and our task here was to reaffirm the work that we had all done. And so that was a little nervous, but because we have a fresh group, but the bidirectional group for the most part, reaffirmed pretty much where we had left off from, so that was a little bit reassuring. But part of the work that we had done was when we took a look at our project approach and the work groups, was we really did want to make sure that we could serve people with low income, low needs, moderate needs, and severe mental illness. And so in our efforts today, and what we talked about was assuring that we could do that. So the BREATHE collaborative model is really a population-based approach to identifying people with mental health issues and needs. Collaborative care model is kind of the other end of the spectrum. It's really identifying people with higher levels of needs and being able to serve them in a targeted fashion. And we reaffirmed that we wanted to be able to do that. We also reaffirmed that we wanted to be able to serve people in provide integrated care, behavioral health in a primary care setting, as well as making sure that we can serve them primary care in a behavioral health setting. So that was sort of our beginning point. And then we had a very spirited discussion about our target population because we were fairly, and I had forgotten this, but we were fairly targeted when we left off because we had identified, or Wes had told us that what we chose was about 37,000 people because we chose Medicaid beneficiaries with co-occurring behavioral health and substance abuse conditions with one or more chronic care conditions. So that was pretty specific. We kind of forgot that that's where we targeted, but that's the group that we want to be measuring, not just the population that we want to serve. So we anticipate that we'll serve a much larger group. And then finally, on the scaling, we talked about things about making sure that we had all the right partners at the table, and basically our partners include everybody. So we talked about making sure that we had school systems, workforce, higher education partners, the penal system involved. Obviously, the payers are here with us already, and we were really trying to think about people that weren't at the table, but we really think that we need to make sure that we've got all of the right partners in order to maintain and sustain full transformation.
And then, Rhonda, did you recall how many organizations?
We had 13 at the table.
13 at the table. Great. And Kevin, do you remember how many organizations you had at the table? I think 12 or 13. Okay. Great. All right. Devta, you want to tell us what's transpired with your group and chronic care models? If you remember. Okay, you got all sorts of
so we talked about, we kind of, actually, I kind of echo what Rhonda said, but we affirmed, we had a lot of new members and some people that didn't participate when we started meeting originally. And so we did affirm all the interventions that we had identified, and we also, one visual that talked about mental health is something that we hadn't used in the past. So we know that we will have to have some communication because some of the interventions that we have on the 4 or 5 are not specific. So we will be in 5 to 7 for those forecasts. So that was one kind of a to-do for us later. And we did talk a lot about our target population, exactly what Rhonda said and what we talked about, that we did not want to see that specific in that description that she shared. So we did that, and we'll be sending that over. We basically just kind of raised our target population, excluding that. How to scale, we talked a little bit about scaling some of these other state projects to some of the smaller counties and some of the challenges around just the participation. So some of these other state projects, we have to have so many. Having acquired more participants in some counties, it would be hard for them to have this many participants in the program. So we talked a little bit about the challenges and maybe some solutions would be using technology as part of the perhaps guidelines from an educator in the app and some of the smaller counties then we did talk about our CSAs, and I can't tell you how many people submitted them or how many participants
Yeah, that's for a show of hands.
Yeah, but we did talk about most of us are wanting to participate into our CSA, the evidence-based programs that we outlined on there. So there wasn't any that we wanted to exclude or delete from the list. Did I miss any?
Thank you. Last but not least.
Oh, okay. Okay, I'm with the Opioid Demonstration Project group, and we had 15 different agencies. We probably had 2 or 3 of us that had been there for the days. We had a lot of new faces, some that unfortunately did not complete the CSA, but that still want to be a part of the solution, so I was really happy to hear that. We reviewed our project ideas that started several years ago, of course, have evolved throughout the course of this, but we looked at our evidence-based practices and the clinical guidelines. We did talk a little bit more about incorporating ASAM guidelines and incorporating the SUD network into our project model, which I thought was a great communication. There was a theme throughout the discussion around communication in a very siloed sector. So it's going to be a challenge with our HIPAA restrictions, but we wanted to try to push the bounds on that and explore what options we do have. And it's not just about sharing information regarding individual patients, but also creating some sort of a communication network among interested parties going forward about how to address this crisis together. We didn't want that to end with this project. The other thing that we talked about extensively was our target population. At first, we really focused on individual patients that have high morphine equivalents alongside concurrent sedatives because of the increased risk for overdose. We expanded that and decided that we probably should be focusing more on pregnant women with OUD for the neonatal abstinence syndrome that occurs, as well as folks, the youth that are using opioids, and we have a unique issue with elderly folks with OUD, which we hadn't really thought about. So that was some really great input there. We also wanted to do some work with patients that have had overdoses in the past and focus on IV drug users. So we really had a good discussion around that target population, and we have to be careful because we have so many patients with OUD that we really don't want to bite off more than their shoe. So we really felt that as we expand this project and move it upstream and support primary care clinics and MAT providers with appropriate prescribing and recovery and wraparound services, that's going to expand our population as we move forward in the project, because we're really going to focus more on preventing OUD, not just addressing current OUD. The other thing that we talked about is the key partners. And when we address youth, we need to be thinking about the educational system and how we can incorporate them into our solution, as well as housing partners, not just in sober and clean living, but also in low barrier housing that we need to have available, as well as the key importance of job training or reentry of these individuals back into the community.
Wow. Okay. Sure, that lots of ground. You want to?
Just to add to this, first of all, I want to thank again Yakima Valley Farm Workers Clinic, Yakima Neighborhood Health Services, Consistent Care Services for providing us with phone support for those who wanted to participate on the phone. We can't tell you how much that really helped us. We appreciate that. Also, those individuals who have your notebooks for your particular project areas, we'd like those back. However, what we would like to do is a take-home assignment for the project facilitators. We know how super busy you are, but what you talked about in your summary, if you could write that up in some way and give it to us. Carol and I and the rest of our staff are the ones who are writing that semi-annual report, and we need this information from you. So please, if you could provide that to us, that would be very helpful.
And last but not least, Carol, maybe you want to come on and talk about it, but would you like to continue this sort of a dialogue in subsequent months among the core tables? Carol has had this notion of a learning collaborative, and it seems like we got up to a great start with that sort of discussion today. So you want to briefly? sort of touch on what might happen.
So how many of you would be willing to be part of a learning collaborative with your project team? Would that be useful to share best practices? Great, because it really is, as part of practice transformation, part of technical assistance are these learning collaboratives, because we know that we can share with one another the experiences that we've had in our communities. So the idea is after July is to reconvene you as learning collaboratives. And what that means for the project facilitators is that we have resources and that we can bring in special people, we can bring in expertise. We've got the AIM Center at the University of Washington. So there are other technical resources that we can endow your team. So that is part of our next step after we get the project plan written, because we think that learning collaboratives, which have been established in other ACHs, are a great way to share information. It will require, us organizing how those look, working with each project team facilitator. Now it's going to be learning collaborative facilitators to determine what exactly your team wants. What kind of information do you want? How often do you want needs? So it wouldn't necessarily use this time that you would be on your own as you. So if that sounds good, you will move forward with that.
No, I'm done. No
meeting next month.
No meeting in July.
We'll be in cave. So thank you very much.
We will reconvene in August. Thank you.
Okay.